Yeah, thank you, Dr. Gupta, for including me in your most successfully running horror series, Dare to Bear. Which season is it? 10, 12? I think it's been more than that. Uh, anyway, so in oculoplasty, we actually are more accustomed to get aftershocks. So this kind of aftershocks really give us the most trouble. So I'll be telling you the story of a series of aftershocks I got in quite a few number of cases, and this is still running on. Uh, this is case one in the series. A male child, 15 years, with having a simple swelling in the right upper lid for 2 years, no other abnormality. On everting the lid, there was a cystic appearance of the swelling. So the surgeon decides to go for a surgical excision through a skin approach under general anesthesia. But after the surgery, in post-operative period, 10-day post-op, it was found that there is some amount of the cyst is still remaining, and he is having a complete ptosis of that eye. So patient and patient party was much aggrieved. So then we planned for a residual cyst excision 2 months later, but his ptosis was still persisting. And then 7 months following the second surgery, we took him up for ptosis correction through LPS resection and anastomosis. And thankfully, till date, he is doing fine. So when a second case with similar presentation came to us, male child, 28 years, 1 year duration of swelling, ptosis. There was a huge cystic swelling from the superior border of the tarsus, no other ocular abnormality. Then the wise surgeon I am, I thought that probably the skin approach was the culprit first time. We did injure the LPS aponeurosis somehow, and we thought a conjunctival approach will be a safer procedure. We did a conjunctival approach, did the excision of the cyst, and unfortunately, the same result postoperatively. It is near complete ptosis of the left eye, and this patient was so aggrieved that we lost him to follow. Both time the histopathology came out that is a benign cystic lesion with fibrous tissue. So where were we going wrong? So this is the anatomy of the lid, the levator aponeurosis getting inserted on the anterior surface of the tarsus, and we are getting the cyst somewhere here on either through skin approach or through conjunctival approach. We are somehow damaging the whole of the levator aponeurosis. So which approach will be safer, the skin approach or the conjunctival approach? And if we get similar cases in future, which way to go? Or should we at all intervene in these cases? So as usual, we got a third case in the series, 38 years males with a 1 year swelling, mechanical ptosis with some hypertrophy of the left eye. And we did a CT scan this time. We get a huge orbital swelling. This is the finding of the CT scan. And there's a huge cystic swelling. So this time we try to find a safer approach. But before going to that, we got a similar case. Before operating the third case, we actually got the fourth case of the series, the same presentation, 42 years male, cystic upper tarsal swelling, 8 months, no other ocular abnormality, CT scan showing an orbital swelling. So we tried to find a safer approach that we are causing damage to the levator aponeurosis. So we thought that better we go through a skin approach, just like a ptosis surgery. We isolate the levator aponeurosis, we disinsert it from the tarsus, isolate it, hold it with stray sutures, and then do the excision of the cyst. And then accordingly, we shorten the levator aponeurosis, tighten it a bit, and fix it back to the anterior surface of the tarsus. So here we are trying to separate the orbital septum to get the levator aponeurosis free. So this is the White-Knowles ligament, the fibrous attachment on the where the levator aponeurosis changes to its muscular structure and changes direction also. So after we disinsert the levator from the tarsus, then we try to dissect the cyst, and we found that the cyst was quite adherent to the conjunctiva. There's a full thickness conjunctival hole, and it was also adherent to the, at the margin of the White-Knowles ligament, it was adherent to the levator. So after excision of the cyst, then we suture back the levator, we tighten it, resect a part of the levator aponeurosis, and then suture it back to the tarsus. On the table, we can titrate it according to the necessity, how much lead correction should be done. So it's just like the rest of the thing is just like ptosis surgery. We have we just fix the levator there and see how much we can elevate the lead in normal eye position, and any reinforced sutures needed, we can do that also to titrate the maximum of the levator aponeurosis. So on table, it seems that we achieved satisfactory lead position, and then enclose the skin. But unfortunately, 2 weeks post-op is the same frustrating result. Yet again, it's almost a neotosis. So we have to wait and watch to see what comes out. But luckily, 2 months post-op, when the edema subsided, the lid comes almost to a normal position. There is no hypertrophy of the eye. There is good movement of the eye also. So it's face savior for the surgeon, and probably this gives us this encouraging result gave us a more efficient skill. And in the 4th case of the series, we even in the first post-op checkup, we found that the patient had no ptosis in the postoperative period. But these are the whole case series. But the puzzle continues that what approach should we do for this kind of excision, or should we intervene at all in these cases? I didn't find any reference of a similar kind of complication in the literature search. Thank you, everybody. Thank you, Dr. Gupta, for giving me the opportunity. Over to you.